Good morning, everyone. And thank you to Dr. Pandasamy and Dr. Basamani for this kind invitation to speak here. Now, we started this morning off on a high note, talking about the state of the art in terms of medical and endoscopic treatment of IBD. Now, we're going back a bit, as the previous speaker, Professor Riley, said. We are going back to basics here. And minus the second in this session, the talk on basics. So what should I include in this talk on IBD evaluation? And so before the audience gets restless, please let me remind you that we are talking about initial evaluation, that it should be pragmatic, it should be cost effective, and I'm not obviously going to touch on endoscopy and biopsy. So typically, this is what I would do. So we have blood tests. So complete blood counts, ESR, CRP, albumin globulin ratio. I'm talking about basics. I'm talking about the gastroenterologist who occasionally encounters a patient with IBD. Albumin globulin ratio, iron and total iron binding capacity. These are my favorites. Stool test, stool routine analysis, fecal occult blood is extremely important from my point of view. Calprotectin I use sparingly, we'll talk about that a little more. And again, we are talking about initial evaluation, I'm not talking about follow-up here. And finally, imaging. All right, so this is the list of tests which I normally do when I see somebody who I think might have IBD. And I want to make sure that this person does not have IBS. I want to get a little more characterization of the disease. The two tests which I have shaded a little, which appear a little less dull on the slide, which is the ASCA and the calprotectin, are tests that I use less frequently. They are actually kind of second line. So what are the goals of initial evaluation? What we need to do is to diagnose IBD in a patient with chronic GI symptoms. We need to distinguish IBD from other inflammatory diseases of the gut. We would like to distinguish ulcerative colitis from Crohn's disease. We want to know what is the pre-treatment disease activity, and if possible, we'd like to predict response to treatment. We heard from Dr. Uday Kumar that now they are using small molecules in nearly 30% of their patients with IBD. Certainly in India, we have not transitioned to this level, but it doesn't look to be far in coming. What about complete blood counts? For me, hemoglobin and the red blood cells indices are very important, because if I find microcytic anemia, microcytic hypochromic anemia, to me it indicates that this person is losing blood from his GI tract. If there's macrocytic anemia, I might believe that there is small bowel bacterial overgrowth or that there is terminal ileal involvement. The white cell count is important. Platelet count is particularly important. A lot of our patients with Crohn's disease, for instance, will have a high platelet count, 450,000 or more. And when you compare it with intestinal tuberculosis, of course, we've not really done formal studies. With tuberculosis, the degree of thrombocytosis that you get is not this much. There is a bit of work done on the neutrophil lymphocyte ratio, is something that I don't use, but there's a systematic scoping review done, which was published last year, where one of the things they talk about is to distinguish IBD from non-IBD and clinical outcome prediction. So the conclusions of that systematic review were that this very simple test, which is the NLR, differentiates IBD from non-IBD controls. It's useful in assessing disease activity. It may predict risk of complications, and it can guide therapeutic decision-making, specifically the lack of response to infliximab. Now, I'd just like to remind you that there is much experimental evidence which says that inflammatory markers correlate with activity, with disease activity seen on leukocyte scans. In the bar on the left, we have patients who are inflammatory marker positive, which is a white cell count greater than 10,000, or a CRP greater than 7. And those with the inflammatory markers which are positive have a much higher positive scan. And when they are, IM inflammatory markers are negative, the leukocyte scans tend to be negative. What about the utility of ASCA and ANCA? Because these are kind of widely available, on a kind of outsource based in most hospitals. They are widely used, and I sometimes think they are widely misused. Essentially, the serological biomarkers can evaluate an aggressive disease phenotype. They might predict prognosis, and the initial way that they were introduced was that they distinguished Crohn's disease from ulcerative colitis. But if you look at this review, which was in 2016, the conclusion of that, and that was a systematic review, said that serological markers have limited value in making an initial diagnosis of inflammatory bowel disease. So initial evaluation, serological markers, generally no. Fecal calprotectin is another measure that we use. It's increasingly used, and actually it's very heartening that the costs have come down dramatically, maybe within the last year or so. So it's a sensitive and a non-invasive tool distinguishing IBD from IBS. So when you take all patients with chronic diarrhea, and if you use a fecal calprotectin, it distinguishes organic from non-organic almost 100%. In a meta-analysis, which is what I've referred to here, when you screen for suspected IBD, the sensitivity and specificity is like 93% or 96%. And in another meta-analysis, if the fecal calprotectin was less than 40 micrograms per gram, the chance of having IBD was less than 1%. So this is an AGA technical review which was published 3 years ago, basically showing that ESR, the sensitivity and specificity of these non-invasive tests, ESR, CRP, and fecal calprotectin scored highest here. But all of them have their value. So this is a much more recent review, which was systematic review again, published last year. So if you look at hemoglobin, it is not very sensitive. So 37% sensitive, but quite specific, 90% specific. Platelets, a little more sensitive, not equally specific, and so on with ESR and CRP. Albumin, which is one of the things that I talked about, also has a role here. ASCA, although it's reasonably specific, in our setting, I don't think this has been looked at in India because we know that a lot of inflammatory diseases in India, including tuberculosis, can have a positive ASCA. Calprotectin in children in particular is very sensitive, and in adults also it is reasonably sensitive. Distinguishing CD from, so we talked about the initial evaluation. One is to differentiate IBS from IBD. The second is to distinguish Crohn's from ulcerative colitis. And here, the ASCA and ANCA may be useful. So if you use a combination of a positive ASCA and negative P-ANCA, it distinguishes ulcerative colitis from Crohn's in most patients. The question of how rigorously one wants to distinguish ulcerative colitis from Crohn's disease is of course a different issue altogether, because in practice probably it doesn't really make all that much of a difference. What about predicting treatment response? Again, when you see the first patient for the first time, you want to know, is this person going to respond or not? And here's what the information is. You have a high baseline CRP. It predicts that this person will respond poorly to treatment if he's got ulcerative colitis. If the person has Crohn's disease and high baseline CRP, it predicts a non-response to infliximab. A P-ANCA positive Crohn's disease also responds less well to infliximab. And in pediatric Crohn's disease, a positive ANCA predicts a good response to biologics. So this is the kind of information that we have. So moving on to imaging, which is the next pillar of the non-endoscopic initial evaluation. What typically we have tended to do in my hospital is to use CT enterography for adult patients at first presentation. And essentially this is because we feel that the resolution is much higher, we pick up smaller lesions there. And to the trained radiologist's eye, the CT enterograph often provides as much information as MRI. I'm going to contradict this statement a little later, but bear with me. In children, we prefer MR enterography as the first evaluation, and as part of the ISG task force, we have actually talked about guidelines about how to do this. Now, before we go on to CT enterograph, okay, here are CT enterographs. What I would like to remind people, knowing that many of you are not specialist IBD physicians, sorry, going back to the CT enterography, what a lot of patients who come to see me would come with contrast CT scans which use positive oral contrast, and that should be avoided in CT enterography. They should, basically what you're looking at is enhancement. Okay. So here the CT enterography, here basically what it shows you here are typical findings of Crohn's disease, which is the mesenteric border ulceration, the anti-mesenteric sacculation. The combination of this is called the omega loop. And here you see the typical comb sign, the increased vascularity. MR enterography is really much more effective. And here is a kind of collage where this here is a CT enterograph, and in the same patient. So here you see this loop which looks apparently structured. And here again in the MR, you see in the T2 weighted image, you see that this area is dark. In the diffusion weighted imaging, you see the area is bright, suggesting that the structure is largely inflammatory in nature. So MR enterography has really revolutionized the way we look at inflammatory bowel disease. And again, this is a further example of that. The only additional thing which I wish to point out here is that here in this MR enterograph, although these loops look normal, when you look at the diffusion weighted imaging, you see these bright areas which tell you that there is actual inflammation going on there. And this is very useful in the evaluation of small bowel disease, where you don't have colonic disease, your endoscopy is normal, your biopsies are normal. And before you do the capsule enteroscopy, when you do this, you see that there is active small bowel disease in these patients. And with that, I will stop. Thank you.